Okay, so let's try to talk about BPPV, benign positional paroxysmal vertigo. The idea is that BPPV, there are subtypes. One is called canalithiasis and the second is called cupulithiasis. I'm mainly going to talk about canalithiasis. I will just say that in cupulithiasis, the problem is in the capula. There, the otoconias are dislodged, and this is a more severe and harder to treat one with longer periods of vertigo, more rare than canalithiasis. So I'm not going to talk about cupulithiasis. I am mainly going to talk about canalithiasis. And the basic idea is to talk about the semicircular canals in the inner ear and the utricle and the saccule. Those are the anatomical landmarks that we need to know. And on the otolytic organs, which are the saccule and the utricle, and mainly I'm going to talk about the utricle because from there the otoconias, which are types of crystals that should be on the utricle, dislodged and go to one of the semicircular canal. The most common is that the otoconias, those crystals from the utricle usually dislodge, for example, from trauma, from viral infection, and a lot of the time we don't know what caused it, so it's idiopathic. From there, from the utricle usually, the otoconias, those crystals, they go to the semicircular canal, to one of them. There are three semicircular canals, anterior, posterior, or if you want superior, no, let's call it anterior, posterior, and horizontal semicircular canals, or anterior, posterior, and lateral semicircular canals, or superior, inferior, and lateral, whatever. They usually go to the posterior, or other name is the inferior semicircular canal. Sometimes they go to the horizontal, which is the lateral semicircular canal. It's more rare. The most common one is the posterior. They go to the posterior or inferior. The posterior inferior is the same one. So they go to the posterior semicircular canal. This is the most common. So the most common pathophysiology of BPPV is otoconias, those crystals from the utricle dislodge from trauma, from viral infection, from idiopathic cause, and go to the posterior semicircular canals. In the canal, and they cause a clot and aggregation, and this aggregation can move in the semicircular canal, and this movement cause vertigo. It initiate movement of the fluid in the semicircular canal, and this cause a movement and feeling of spinning when you are not moving at all. So it usually happens, those attacks, where the patient moves, and this is because he cause, when the patient moves, he cause the clot in the semicircular canal to move, and this movement cause vertigo and the symptoms that the patient feel, usually in the posterior semicircular canal. Now, sometimes after the patient again move and again and again and again in the same day, this clot a little bit dissolves, so the patient less feel the symptoms. It gets better. But after a rest, prolonged rest, again the clot aggregates and again all the symptoms come back. So, for example, after a night's sleep, when he wakes up and moves again, so he will feel again all the symptoms, because again he will have this clot, this aggregation of otoconias, and again when he will move, the clot will move in the semicircular canal, usually the posterior one, and cause movement of the fluid, perilymph and endolymph there, and this will cause feeling of movement, this vertigo that it causes, and this is the problem. Now, it usually comes in attacks. The attacks are seconds to minutes, not very long, and it can come back, come and go. In order to diagnose this, there is a maneuver which is called Dick's Hall-Pike test for posterior semicircular canal. For the horizontal canals, which is much less common, the roll test is the test. Now in Dix-Hallpike, you take the patient, you tell him to sit down, you take him to his back while his head one time rolled 45 degrees to this side and the other one 45 degrees to the other. In one time you take it and you take him down, the head a little bit out of the bed, and in the other time you take it to the 45 degrees to the other side, and then takes him back, and this should cause vertigo. Now, the vertigo of the posterior semicircular canal when the BPPV is because of canal lithiasis in the posterior semicircular canal, what you will see when you do this Dix-Hallpike maneuver, you will see torsional nystagmus. Torsional nystagmus. This is the most common nystagmus for posterior semicircular canal lithiasis BPPV. And this is important because horizontal canal BPPV will cause geotropic horizontal nystagmus and not rotatory nystagmus. Okay, so in posterior semicircular canal there is a rotatory nystagmus. This is what I said, right? Rotatory nystagmus. And in horizontal canal BPPV there will be horizontal geotropic nystagmus. I mean, if you lie down, it will be to the beat. The fast phase of the nystagmus should be to the ground. Like sometimes I hear that it's sometimes agiotropic if you are doing it to the side that is healthy, or geotropic. It should be horizontal. Okay. In posterior semicircular canal, the nystagmus will be rotatory, like this, and it will fade with fixation as all the peripheral nystagmus should. It also fatigue. I mean, if you do it again and again, Dix-Hallpike, the patient should fatigue, because as you remember from the first that I talked about what happens if the patient again and again move, the clot a little bit dissolves, and after rest the clot again aggregates. So if you do again and again the Dix-Hallpike, he should fatigue. The treatment for posterior semicircular canal BPPV canal lithiasis is the Apley maneuver. You start the Apley maneuver exactly like Dix-Hallpike, to the side of the problem, and then you will see in the papers or in the internet, you are moving the patient from the side you take him down to the other side, 90 degree, 30 seconds wait, then again 90 degree, 90 seconds, 30 seconds wait, and then take him up. So again, you are taking him down 45 degrees to the disease part, wait 30 seconds, doing a to the other side, to the healthy side, doing a 90-degree shift, waiting 30 seconds, and then again take him to the side, and again 90 degrees to the side of the healthy side, wait 30 seconds, and then take the patient up and wait for about 5 minutes. Now you do it, if you feel it's better, it means that it works, and you can do it sometimes again and again, and you should feel better. Now remember that posterior semicircular canal can return, can come back around 50% to 15% to 50% risk in 1 year that the BPPV will come back. Even some books say that from posterior semicircular canal, what you are doing can cause the dissolved clot to go to the horizontal canal, and then you move from posterior semicircular canal to horizontal canal BPPV. Now, what you are doing in the Apley maneuver, you move the clot. You move the clot from semicircular canal, you try to get him back to where he should be, the otolytic organs, the otocorneas come back to the otolytic organs, this is the theory, and it should work. It should work. If you, again, doing an Apley maneuver to the right side and to a posterior semicircular canal, not horizontal, the Apley maneuver. There is another maneuver for horizontal canal. The idea of the horizontal canal maneuver is that you take the patient, take him down to the healthy side, then doing a 90-degree rotation, again wait and then come back. This is the a way to do a maneuver for a horizontal canal BPPV. Remember that horizontal canal BPPV, horizontal nystagmus, and much rarer horizontal nystagmus when you're doing the roll test for horizontal canal. For posterior semicircular canal, the Dix-Hallpike is the gold standard for diagnosis. Now, I say the Dix-Hallpike because if you are thinking about a vestibular test, for example, V-HEAT, or for example, caloric test, or for example, SHA in rotatory chair, or I don't know, SVV, or whatever, or VNG. This is not the gold standard. The gold standard for diagnosis of BPPV is the Dix-Hallpike test. There are some things that you can find, for example, in caloric tests, sometimes directional preponderance, you may see a direction of nystagmus to one side, not the other. There are things that you may find but the core standard for diagnosis semicircular BPPV is the physical examination, is the history, is the story plus the Dix-Hallpike, which should be positive with the right nystagmus and fatigue, and again without any neurological deficiencies. There should not be any I don't know, tinnitus or problems in the, except for Dix-Hallpike, not many, no, not any neurological manifestations. Okay, these are some words about BPPV, benign positional paroxysmal vertigo, or benign paroxysmal positional vertigo. I talked about what it is, the autolytic organs, the otoconia, dissolved, go to the semicircular canal. There is canaldiasis, more common. Copulitiasis, I didn't talk too much about it. Posterior semicircular canal is the most common. Horizontal canal is less common. For posterior semicircular canal, BPPV, do the Dix-Hallpike. If it's positive, in the side it's positive. This is the diseased side. Do Apley maneuver, you can return on it. For horizontal semicircular canal BPPV, do the roll test. If it's positive, do a maneuver for this, and remember that it may come back, and that's it. No neurological deficiencies for the patient, and this is it. This is about BPPV, and thank you very much. If there are any mistakes or corrections, please tell me. Sorry for any mistake, and this is it. That's it.